Again, this is Dr. Hoagland again for the last module of this course. And it's in this section, you'll be observing some videos of audiology in interactions with children. And to go with this, I want to do a quick review of audiology in general and focus in on working with children. So for the adult section, I did not worry about talking about audiometry. So I'm going to do a quick review now just to make sure this is all very familiar with you again. Pure tone audiometry is what we start with. This is our primary measure. We have a number of other tests, but I'm going to focus on these today as we're talking about hearing loss in a very general sense. Consider that you have had information about audiology in more depth in other courses. So this is just that refresher. So pure tone audiometry is the one test that we start with. That's our primary test. All others are intended to help delineate hearing loss more exactly. This gives us that first idea if there's a hearing loss or not. It's the most common clinical test to determine the hearing threshold. We present sounds through earphones and ask the listener to respond when the sound is detected. This is what we all have done throughout school. School nurses, counselors, whoever administered these at a screening level in school. So if you were fortunate, you had an audiologist at your school and the audiologist did these tests. Again, at school, it's a screening level, but this is the same idea. Listening over headphones or an earbud type insert, and then just raising your hand, pushing a button when you hear a sound. The thresholds are plotted on a diagram called an audiogram, and I've got an audiometry video here for you to watch if you choose to have that refresher. I'm going to take a few slides here just to quickly review the audiogram. Again, this should be familiar to you. First of all, the audiogram is a graph that looks like this. We measure in octave measures, 250 hertz, 500, 1,000, 2,000, 4,000, and 8,000 hertz. Audiograms generally have another line in between at half octaves because in the case of some hearing losses, those additional frequencies will be measured. On this particular image, I have highlighted that the intensity is measured in decibels from top to bottom. So the softest sounds are at the top and the loudest sounds are at the bottom. So when you have an audiogram, if all of your thresholds are marked at the top, that's good. If it's above the 20 dB line, that's considered normal hearing. The lower your thresholds are on this diagram, the more hearing loss you are exhibiting. So in this particular image, I've highlighted intensity going vertically. In this one, we're talking about frequency measured in hertz going horizontally. The left is the lower frequency or lower pitch sounds, and to the right are the higher frequency or higher pitch sounds. And remember that frequency and pitch are not exactly the same thing. Intensity and loudness are not exactly the same thing, but they're measuring the same direction on an audiogram. So we frequently will use those terms interchangeably, even though they're not the same. This next illustration I have here is an audiogram with familiar sounds plotted on it. So you see various consonants that are in speech in there, all in the range of that yellow shape, which was frequently referred to as the speech banana. And so the speech sounds are marked on there, and a variety of other environmental sounds you might be exposed to, from very soft things like rustling leaves, all the way up to very loud things like firecrackers, airplanes, sirens, things like that, to give you an idea of how these environmental sounds fit into our world and our hearing. On this slide, I have just designated ranges for different levels of hearing loss, how we classify hearing loss. On the left, you see that in the form of the audiogram with shading to indicate what range that level of hearing loss is going to be seen on the audiogram. To the right, I have the numbers that fit that category, that separate those different levels. and some characteristics you might see related to what's missed with that level of hearing loss. Again, my image is over the bottom portion, but these are in separate slides also on Carmen so that you can see that the rest of the section on the profound hearing, so you can see that. But we see a lot of information that gets lost as the hearing loss increases. This slide, I just have those two illustrations next to each other so you can put those into context. The level of hearing loss and how much is lost in terms of speech sounds as well as environmental sounds. So this is just for you to have a visual opportunity to just put that into context, hearing loss and variety of sounds we experience in our daily environment. Next, going back to the idea of the audiogram specifically, when we do an audiogram, we measure each ear separately. Again, you're familiar with this from coursework as well as from practical experience as you've had hearing screenings throughout your life. But when you're marking an audiogram, the right ear is always marked as a 0, a circle in red. And the tip that's always makes it easy to remember which symbols indicates which ear is red, right, and round go with the right ear. So red, right, and round always go together. Those R's always go with the right ear. And in contrast, the X is blue for the left ear. Red and blue makes it very easy to distinguish when you're looking at audiogram. The difference in shape of the symbol is if you have an audiogram that's not in color. That used to be a bigger thing when printing, copying was all in black ink. Now it's with color printers, it's a little bit less of an issue, but it still comes up often enough. Those symbols are important. The audiometry, the pure tone audiogram, helps us to determine the source of the problem, the middle ear or the cochlea, and technically also the outer ear, but we're determining the type of hearing loss by using audiometry. And I'll get into that just a little bit more as we go along. Again, this should all be familiar to you. This is just indicated to, this is all this is all intended, to help you refresh your memory, make sure this is all in your mind currently. Now, the audiogram is used to help us determine the two types of hearing loss. Actually, three types. We'll get into that again. And I mentioned this with the adult hearing loss section as well. We have conductive hearing loss and sensorineural hearing loss. Again, I've talked about this before. We're just refreshing. Conductive hearing loss is a problem with conduction of sound. Sound can't get through the middle ear, or the outer ear too, although outer ear problems are a bit less common in most people. The biggest thing in an outer ear is a blockage. Typically, it's caused by wax buildup, infection, and physical abnormality. Again, I have on here middle ear, but middle ear is the later stage. This also includes outer ear. The results of the audiogram will indicate hearing loss when sounds are presented via air, but better hearing when sounds are presented via bone. I have not talked about bone yet. I've just talked about air conduction in the audiogram. We'll get to bone conduction shortly, and just to make sure you remember that. So conductive hearing loss is just in the outer and middle ear. Sound is not being conducted into the inner ear in order to hear it, to process it. The other type of hearing loss is sensorineural hearing loss, and that involves the neural structures of the hearing system. That's the cochlea and beyond up to the brain. Due to damage to the cochlea or neural structures, it can be anywhere along the line. We talked about some issues with adults, such as the acoustic neuromas, that are definitely sensorineural. In fact, most adult issues are sensorineural. But in this case, we're looking at children, and we'll see a little bit of difference in that. The nature and loss depends on the cause, and it can occur in one or both ears depending on what's causing the sensorineural hearing loss. The range in severity is mild to severe, or actually mild to profound. Even though I have severe here, it can be profound in sensorineural hearing loss. So the third kind I alluded to is actually the mixed hearing loss, and I mentioned this briefly in the adult section as well. This is when a person can have both conductive and sensorineural hearing loss. Audiogram will show bone conduction results better in air, but not within normal limits. So say you have a sensorineural hearing loss, plus you have a middle ear infection, you will have a mixed loss. And this audiogram indicates a mixed loss. The bone conduction symbols on here are elevated, but better than air conduction thresholds. In the PowerPoint slides I have to go along with this, I have a little bit more information in there about the symbols related to audiograms. Refer back to that if you need more refresher on the symbols themselves. Now I talked about bone conduction testing, and so I'm going to come back to this now. Again, this all relates to adults as well. I just didn't talk about it at that time. Bone conduction testing is testing the hearing thresholds with a vibrator on the bone behind the ear. So the mastoid bone immediately behind the ear. If you feel behind your ear, there you can feel a bulge of bone. That's the bone the vibrator is rested on. This way, the sound is bypassing the outer and middle ears, going directly to the cochlea through the bone. So your skull is actually transmitting the sound into the cochlea. Then the results are plotted on the audiogram, as I showed in the previous slide, with the brackets for the right and left ears. This allows that bone conduction allows us to tell the difference in conductive versus sensorineural hearing loss versus mixed. I apologize for moving ahead too fast. I added that sentence at the last moment. So when we're talking about children specifically, we may have to make some adjustments to how we do an audiogram. As an adult, the person can attend to the task, follow instructions, and complete an audiogram the way we usually think of it. But when you want to test a very small child, they can't sit and follow instructions quite the same way. So a couple strategies that are used are visual reinforcement audiometry. This is used in very, very young children, infants from 5 months to 2 to 2.5 years of age. This way the children don't have to learn to follow instructions. They're given visual rewards when there's an auditory stimulus. So when they respond to an auditory stimulus, they get movement, some kind of a visual response that they can attend to. I have a video attached here so you can see that as well, see an example of that. This is used in small children, again, who cannot follow instructions accurately and don't understand the task. They're used, a behavioral response is used for this. Behavioral response to an outside stimulus specifically. Another strategy that's used with children is conditioned play audiometry, and this is used for children who are a little bit older, 2.5 to 4 years, still not quite old enough to consistently follow commands needed for an audiogram for older individuals. But the children are taught to do something when they hear a sound. So they don't have to raise their hand, they don't have to push a button, things like that. But when they hear a sound, they do something, and there's some training involved so they know to do that. Again, I have a video linked here and in the PowerPoint slides to allow you to go observe a bit of this. In very, very small children, you might use a different test altogether, a brainstem audiometry, auditory brainstem response. And I'm not discussing that here because that's not quite the focus here. We're talking about this for a different purpose, but that's also relevant because we can also identify hearing loss in very small children younger than 5 months. So types of hearing loss, when we're talking specifically about children, is primarily, it's different than adults. Childhood hearing loss can be permanent or temporary, again, depending on the cause. And is it within the peripheral or the central auditory system? Where is it in the peripheral system? So we can, a lot of times for children, a hearing loss can be temporary, where in adults it's mostly going to be permanent. Temporary hearing losses in children occur mostly, and again, are associated with transient infections in the middle ear. So most of the hearing losses we see in children are related to middle ear infections. And those can go away. Infections can be treated or will go away on their own. So most of the hearing loss we see in children consists of that. So conductive hearing loss in children then, remember I've already talked about conductive hearing loss being in the outer and middle ears when sound is not being conducted into the cochlea, into the inner ear. So a lot of times that'll be wax buildup. In children, it might be another blockage. It could be something that they stick in their ear or something like that. There are any number of things that can build up in the outer ear or be put into the outer ear to occlude that. So wax buildup, foreign objects can cause a conductive hearing loss in children. Fluid in the middle ear can cause that. And fluid in the middle ear is pretty consistently associated with middle ear infection. So that can cause a conductive hearing loss. And a physical abnormality can result in a conductive hearing loss. I worked with a young boy years ago who was born with an auditory atresia. He did not have an outer ear canal, therefore he had a conductive hearing loss in that ear. Sound did not have a canal to go through, so therefore it could not get into the cochlea effectively, and therefore he had a conductive hearing loss. This is the most common type of hearing loss in children. Most children will have primarily middle ear infections, but these any kind of a blockage and occlusion in the outer ear can also happen. So when we're talking about hearing loss with children, this is the most common kind. Sensory neural hearing loss involves the neural structures of the sensory system in the cochlea or beyond into the central nervous system. It can occur unilaterally or bilaterally, so it depends on the cause, whether it's one side or both sides. It can range from mild to total deafness, so a child could be deaf in one or both ears. It can occur with conductive hearing loss, again, a mixed hearing loss. If a child has a sensory neural hearing loss and develops a middle ear infection, they'll have a mixed loss. This can also be either congenital or acquired. So congenitally, it can happen before birth, at birth, after birth. It can be inherited. So congenital means they get it through the family. Acquired can be a separate sort of a cause. That's something that they develop afterwards, separately from genetics. I'm just going to go really quick. I'm not going to go through this whole list here, but just identification of causes of hearing loss. About half of children's hearing losses are environmental, and I've got a list of possible reasons for that, including ototoxicity that we talked about with adults. Rubella. If you've ever heard of the risks of rubella, deafness and hearing loss is a major risk that comes from that. The other 50% are genetics. Some of them are non-syndromic. More than half of those are just passed on, inherited from the parent. And the other 15% of these are parts of syndromes, various medical diagnoses that include hearing loss as part of the symptoms. I want to focus just a bit on otitis media because, again, that's the most common cause of conductive hearing loss in children. It's the most common childhood illness. It tops any other diagnoses that children may have. This results in that infection results in inflammation in the middle ear space. It can have fluid in there, or it can happen without fluid, and the symptoms that we see with either of those scenarios is different, and you've probably had that information elsewhere, but it's inflammation in the middle ear space. And again, sometimes the fluid builds up behind the eardrum, sometimes it doesn't, and in either case, the mobility of the eardrum is affected. It's restricted because of this infection. And again, I have a video linked here so you can look for more information related to otitis media. I'm going to end up here today too. I talked about with adults with hearing aids and recommendations for hearing aids and factors that need to be considered with that. I'm going to also talk about factors that are related to long-term outcomes in children with hearing loss, because we know that hearing loss in children can affect language acquisition, academic skills, things like that, because of those difficulties with learning language and the impacts that language can have on other aspects of success. So long-term outcomes that we need to consider depend a lot on the severity of the hearing loss. So a child who has a mild hearing loss, and I've got some percentages on here, a child with a mild hearing loss will have less impact on long-term outcomes than the child with profound hearing loss. Makes a big difference for us. And some of the treatments we talked about related to adults also can relate to children as well. Time of onset makes a big difference. A long-term outcome for a child is going to be affected a lot by whether it's congenital hearing loss, so they're born with it, or it develops early on because they were born with that tendency, Or if it's acquired, it could be acquired after they've acquired language, and therefore the outcomes will be different if they've had language exposure before the hearing loss or not. The etiology and type of hearing loss. If it's middle ear infections, it depends on the frequency of the middle ear infections, how much impact it will have. Is it a sensory neural hearing loss? That's going to have a difference as well. Is that hearing loss related to a syndrome, or is it just passed on from parents? That can make a difference, because a syndrome may have different impacts on the child than in addition to the hearing. Age of identification and intervention. And over the years, we have gotten much, much more consistent about screening newborns. So now every state requires hearing screenings for newborns. So now the average age of identification of hearing loss in children has gone from 2.5 to 3 years of age down to 2 to 3 months of age. So infants are consistently screened before they are discharged from the hospital when they're born, and so that if they fail that screening, they can get a diagnosis within the first couple months. So we have a much earlier diagnosis, so that changes long-term outcomes for children. That age has, by getting better, means outcomes overall are better for children with hearing loss, because they can get intervention earlier when they need to acquire language. Presence of additional disabilities in general health. Again, if it's part of a syndrome, that's going to make a difference. If there are other issues going on with the child, that will interact with the hearing loss and affect long-term outcome as well. And there's a lot of environmental factors, similar but also different than with adults. Family support makes a big difference. If the child has a hearing loss with a very, very supportive family with the ability to get medical care, that's going to be a different outcome. If they're able to afford a hearing aid, if a hearing aid is recommended, any sorts of things. All this ability to access strategies, techniques, rehabilitation, things like that, that all makes a big difference on the outcome. So this is the summary I wanted to give you for the children, hearing loss in children videos that you'll be watching on Carmen. So keep this information in mind as well when you're watching those videos and as you're answering the questions that follow each of those videos. This is basic information. Some of this applies to adults as well as children, but this is more information about how we'll address children and hearing losses. So enjoy this last module, and I'll follow up with you at the end.